Good afternoon, everybody, and hope you enjoyed your delicious lunch here at the DHS2. I have to say, it's been a real delight. Lunchtimes here for now. So this is a sort of a very quick case study of the NeoTree organisation. We're a small charity from the UK, and we're operational in Malawi and Zimbabwe. And it's a use case of how the NeoTree mobile app, which is deployed in nurseries within Malawi and Zimbabwe to assist doctors and nurses give better care to really sick newborns in those nurseries. And so it's patient level data, and this use case is how we're aggregating that in the DHIS2, and some of the comparisons and lessons that we've had from that. With the Norwegian embassy in Malawi and their visas. The entire Ministry of Health in Malawi didn't manage to make it, and neither did my colleague Blessings. So we hope that the DHS and University of Oslo will continue to put pressure on the embassy there to stop their preventative process of getting visas for people from these countries. We've got our funders there at the bottom, so thanks to them. So we'll just move through the presentation, which is not. Okay, perfect. So a quick introduction. I think there are 2.3 million babies will die annually in their first year of life, and NeoTree is a small charity trying to eradicate preventable infant mortality and morbidity using a digital mobile app. And we've had some success in our project so far. So this graph on the on your right is from one of our sites, showing a reduction in CFR case fatality rate since our introduction. Now, of course, with all of these things, it's difficult to tease out exactly what was the element that created that reduction, because we do a needs assessment before we go into any sites to identify the skills, the resources, the physical environment that we're going to be operating in, because then we can tailor the content of the NeoTree mobile app to be sensitive to that and to be most effective. So when we go in, we'll identify that there's not enough staffing in these places, people need more training. And so what we can see here is a reduction in the case fatality rate, but that a lot of that will be to do with training and advocating for new staff, as well as improving and supporting healthcare through the mobile app. So we're currently operational in 5 sites in Malawi and 4 sites in Zimbabwe. We're a low cost system. It's a mobile app that exists on Amazon Fires or low cost Android devices, and we support the healthcare workers in clinical decision support through surfacing local guidelines and international guidelines at the point of care. And then at the end of the admission examination, we use clinical algorithms to then suggest clinical diagnosis to those healthcare workers, and then show them the management for those diagnoses to improve the care of those babies. Because it's patient level care, because it's at the bedside and collected by healthcare workers, it's high quality digital data, and that data is then used for better decision making at the bedside, at the department level, and hopefully at the policy level as well. So quick overview of the app. So these screen grabs here are just sort of an indication of how it looks to a user. A baby will be admitted to a nursery, and the nurse or the doctor, usually the nurse, will pick up the NeoTree and select which form they want to use, either to admit or discharge the baby. And then it takes them through a standardized emergency triage of the baby, vital signs data collection, and then a head-to-toe examination, symptom review, etc. And that's standardized. So we're training doctors and nurses to do it in a specific way. And all of that is supported by local guidelines and international guidelines, which, depending on the entries that a doctor or nurse will put in, then it will surface those guidelines and surface those treatment plans at the appropriate time of when a baby is being admitted. It's the diagnostic support is based on clinical algorithms. So we have a clinical governance board made up of local clinicians, international clinicians, who will agree what those diagnostic algorithms look like and when they are surfaced and triggered in the appropriate manner to support the care of that baby. A key thing that we do is that whenever we implement in a facility is we replace the paper forms, the Ministry of Health paper forms. So we're not duplicating work for the healthcare worker. We remove the handwritten forms, and then the only way that they can admit or discharge a baby is by using the NeoTree, which then prints out the patient notes in a legible, structured form. And that's a key piece of the puzzle for us that we found has given us such a high amount of data coverage and collection. It's automatic digital data export when there's connection, of course, and we also provide a continuous record for the patient. If a patient is admitted in a primary healthcare centre which has the NeoTree, and then referred to a district or a tertiary healthcare centre which has the NeoTree, they are sent with legible paper forms, but also with a QR code which contains all of their admission data from that first admission, which is then scanned by the receiving facility, and then all of the relevant data is pre-populated in their forms. So we reduce that duplication of data collection and give them exactly the data that was admitted and the reasons why they were referred. So hopefully we improve the speed of which they can do the analysis of examination and diagnosis at that referral centre. And we give a continuous record between primary healthcare settings and the district and tertiary. And because we're including pictures and we're giving a standardized way of examining, we're giving this sort of low dose, high frequency training. These doctors and these nurses that we're dealing with often are kicked straight out of nursing college with very little experience and exposure to the sickest babies on the planet. And they're just thrust into these nurseries and said, here you go, examine, diagnose, treat these babies. And they often are very scared, low on confidence. So we include guidance and training materials which hopefully help and guide them through that examination to help them give better care. So that's a low dose, high frequency training aspect of the NeoTree. And these are just a few examples of the pages that a user will see depending on the inputs that they put in. So for this particular use case, we were comparing our patient level data, which we then aggregated and through an API pushed into a test instance of the DHIS2. And we wanted to compare this data with the currently paper-based data collection that a lot of these settings are using to aggregate their data and then display in the DHIS2. And the methodology of that is through teams of data clerks, hand filling in aggregate data sheets, using the registers, not using the patient's notes, and then filling in aggregate data that you then see and then is reported from the DHIS2. So we wanted to check actually what does our data collection look like in comparison with that. And what we found was that there was some quite big discrepancies. In many cases, the NeoTree would match the DHIS data, but in a lot of other cases, we'd find that the NeoTree would give much higher numbers for certain data elements. And when we looked into some of the reasons as to why this might happen, we were finding that there was transcription errors. This traditional data collection is done at the end of the month. It's difficult to get the records. It's difficult to get the notes. But then also, you've got a team of data clerks who are aggregating this data, who are looking at registers, who are looking at notes, and that requires for these aggregate data elements, it requires a certain level of clinical interpretation. And one data clerk's interpretation of the notes might well be very, very different to a different data clerk's interpretation of the notes. And so not only do you get this transcription error in miscounting, lack of notes, you get a variation in clinical interpretation, which naturally ends up giving you a variation or potentially inaccuracy within the aggregate data that ends up in the DHIS2. So what we did was we took our patient level data collected by the healthcare workers who are clinically trained, and we aggregated that through a data pipeline into the DHIS2. And here's just a few items to show that in green, you've got just the testing the functionality of Neotree into the DHIS2. And then in grey, the Neotree data versus the actual traditional data, and then a variance after, and that was for 3 months of data. And on the bottom line, which is worth looking at, is antibiotic prescription during obstetric care. And you can see in every month that the Neotree is collecting a huge amount more data than what you're finding in the DHIS2. And this was specifically due to traditional data collection, only looking at the nurse's register, not pulling the patient notes, which is where, of course, antibiotic prescription was recorded. So this is just one example of how high quality patient level healthcare worker collected data is superior to the later traditional paper-based data collection. So what we found this was being underreported, and what our next steps are, or what is the opportunity, is that our patient level data, wherever we are based, we would introduce that our healthcare worker patient level data is integrated with the DHIS2 aggregation system. And we would see that automated aggregation reduces the error of transcription and also interpretation error. It reduces the time and cost, so we can get rid of, or we can reassign data clerks to other tasks, and we improve data coverage and accuracy, which helps with decision making. The next steps, we're currently in a 4th month of comparison data to really nail down our signal at the facility that's in Malawi that we're active, and then we're going to present that to hospital management, maternity, and hopefully replace the current data collection with our Neotree data collection. And we then want to roll this out wherever Neotree is located. Ultimately, I think it just shows that patient level healthcare worker collected data is far superior. And ideally, we'd look to integrate with the DHIS2 tracker. One of the challenges, I think, is making sure that we replace the Ministry of Health paper forms. If we're duplicating work for healthcare workers, then often these nurses, doctors are overworked, underpaid, far too busy, and any duplication of data is going to duplication of work is going to result in poor data coverage and data quality. So if you can replace work rather than adding work for them, then that's key to our data collection. And that's the use case for Neotree. Thank you very much.
Can you hear me? Okay. Can you hear me? Oh, okay. Thank you. Okay, thank you. So good afternoon, everyone. Um, my name is David from East Mozambique, and I will share the using of the CHAP to anticipate malaria outbreaks in Mozambique. So according to the World Malaria Report from 2024, Mozambique um, is like globally the case of malaria are about three of about 4% of the case of malaria that contributes to the worldwide, and in the sixth place of malaria death in worldwide. So some climate data like temperature, uh, humidity, and rainfall are considered one to be the influence to the emergence of new case of malaria. And according to the Minister of Health, uh, malaria is one of the main cause of death in Mozambique, and most of the case in children under 5 years old. About 0.5% of the total case of death of malaria are children under 5 years old. So these results reinforce the need of using a CHAP as a platform that can be used to anticipate these events of malaria outbreak. Um, so in Mozambique, the Minister of Health adopted the SISMA. The SISMA is a system, it's a platform for managing all the information about disease in Mozambique. So it's a repository that all the disease in all the country are registered in the system. So it's based on the DHIS2, and it connects all the different sub-module. One of them is the integrated malaria system, which is used by the National Malaria Control Program, is one of these. And at the same point, they will introduce this integrated malaria information store system, which is the IMS, for as a repository for the malaria national control program. And it was introduced in 2016. And basically, this repository it's store all the information regarding to malaria, the surveillance, the entomology, the mosquitoes, all the information related to malaria are stored in this repository. So basically, it took 2 phases in order to be build this malaria repository. The first one, which began with designing some forms to store entomology data, some surveys that were conducted in all the country, and also some supervision and data quality tools, which allows the National Malaria Program to control the malaria. And the second phase, they introduced basically other areas like finance, another surveys, the logistic, the case-based surveillance, and also the early warning system for malaria outbreak detection. Okay, before CHAP, the malaria program has some, let's say, conventional modes to identify outbreaks in the country, but basically using historical data. They used to take historical data and compare the C in a range, the peaks or the seasonality to identify what the months are likely to have more case of malaria and which one are not so many cases. And also they have some indicators, relative risk and also the exceedance probability. This was let's say, a machine learning model that they used based on a regression model, a Bayesian regression model, but only they didn't have a climate data to include into this model. They just used only the malaria case, on the random case. And they didn't have climate variables to include in the models to make accurately in the prediction. So uh, this was not so accurate to them because they couldn't have a way to compare this case with some covariates. And another one is that because the tools that they had, this system, they didn't have autonomy in terms of using. Just some of people could handle with the script and importing the data to their repository. They didn't have a way to manage this system. So it was a big challenge to them to use a tool that could predict some outbreaks. So with the CHAP, they were basically a solution for the malaria program in Mozambique. And there were first some limitations. Okay, we say we had the CHAP, but still had some limitations. One of the limitations was due to the version of the malaria repository, because until now they are using a 236, which is extremely low. Yeah, and there are some specific versions that the CHAP needs an instance that is to have so that they can install the CHAP. So that made us develop an instance for them, a side instance, which they could install this CHAP and also the climate app that we have seen before. So basically, this instance, they integrate the malaria data and climate data into the same instance and generate the predictions and then send to the malaria repository. And this is automatically processed. And this model process this data with the climate data that the malaria program wants and then send the data to their repository. So, and with this CHAP, so they can easily include this climate data into the models and also can allow them to identify outbreaks before it happens in advance, 3 months in advance. And because the malaria in Mozambique differs in terms of some areas, let's say different districts. We have low districts, which some in the south, which they consider the lower districts, and the medium and the north. So it's divided in these 3 areas. So the forecast also take this approach. And they also have a tool now so that they have an interface to manipulate, to choose which model are more suitable to them, and also to evaluate this model with which one is predicting the best results. And also, some of the analysis that they can do with this climate data and malaria case is to see in the past what was the behavior of the climate that conducted some behavior of the malaria case in terms of how was the malaria case into the past and also the conditions of the climate data. So they can have now the temperature, the precipitations, and now we have seen with some updates for the CHAP that because they were also interested in some other covariates to include into the model. So now maybe they are able to include those covariates and see if they can improve the forecast. And we saw also today the NVDA, the index. So that one maybe can be used also to include into the model. And because they also have a plan to extend the using of the CHAP in other areas, like in the entomology, because let's say last week we have great conversations, like a great conference about climate and health, and we saw some, let's say, some behavior about the mosquitoes that can, that some countries have, and also they pretend to use to extend the CHAP to other areas in the malaria programs like entomology, case management. They also want that, and use maybe some predict model in each of these areas to generate some climate informative insight, and then maybe can improve or control the malaria on those areas that are higher risk of occurring. So this is basically the architecture in which the malaria programs wants to extend the using of CHAP. Now they are only using in the surveillance area, but they need to introduce that for entomology, also for case management. They are work basically we are doing with them. For entomology, there are some data collection tools which we are working with them to configure in the DHIS2, and those data also that they collect in Excel sheets, which are going also to be imported to them, so that maybe we can try to do some correlations analysis, and some other analysis maybe can be done combining the climate data and also some maybe mosquitoes data. And even if you can use some models in the CHAP, they also has these intentions of using this CHAP for entomology. And case management, he also the same approach, and then with a dashboard so that they can analyze. Okay, so, and muito obrigado. Yes, thank you. Yeah, thank you.
This is okay.
Please.
Let's make sure this is here.
Okay.
Change your slides, okay?
You hear me?
Yeah.
Okay, okay. So, good afternoon, everyone. Can you hear me? Yeah, yeah. Hello? Testing?
Okay.
Okay, my name is Carlos. I'm from DHIS Mozambique, South Digitos, and I'm here to talk about the climate data repository that we are building for the METOPS. So they say start with a good joke. I don't have one, so please pretend I did a very good one, and let's move on. So I'm gonna go through these topics in this session, just trying to give a little bit of context, some challenges, talking about the climate data repository, and some perspective. Well, within this context, I will talk or trying to give you an overview how we get to this climate data repository, right? So yeah, what we did basically was seeing us in this movement, this new movement, the Climate and Health Initiative, and we saw that we need to put together a group of remarkable people like the Avengers, and we are trying to put these people together to make this project happen with all the success it can be. So the first thing my colleague already talked about the health programs in Mozambique, specific for the malaria. And one of the special people we needed to talk with them was the Met Office in Mozambique. We saw the need to talk with them because they are the ones responsible for the dissemination of the climate data in Mozambique. That's why we approached them, trying to understand how the climate data, trying to understand how they do the forecasting and many other things within this. So talking with them, we kind of identify this workflow they have. This is a very top level overview of how they work within the MET, very top level. Okay, so they have the climate data sources. They have different sectors within the MET, the observation, weather forecasting, climate forecasting, all of these different sectors, and they produce their own information. And this information is shared to the general public or to the partners by Excel files or reports. And in some occasions, they do some workshops with these partners, like the health ministry, and they discussed about what's upcoming in terms of climate, and they can discuss with the ministry how to prevent on this. So basically, this is how they work now, the top level workflow, and we can see that is a process that is still a manual process. So someone needs to be responding these solicitations or requests coming from the partners. Okay, we need this data. So someone needs to go into the PC, download the data, and then send the data to them. So this is what we understood on their current process. So look into this with the MET in Mozambique. We identify these challenges or things that can be improved within the MET. Of course, the first one is related to the external data sharing, how they send data to their partners. Okay, so it's still a manual process, right? And for our experience, we could see that the MET people are very busy people. So this takes time for them. Having this request coming, they need to sit and produce this information and then send it to the partner that requests it. The other things is data complexity, but this is a little bit tricky because we are looking here in a perspective of the people who are trying to consume the data, because the data is not complex for them, for the MET, but we need, let's say for the health sector, we need the data that we can understand, that we can use, that we can, let's say, put on the chart and train the models, right? So we had the chance to look in one of the files they produce. when they do the forecasting, the seasonal forecasting. And yeah, it's a file that, let's say, people with no background maybe cannot understand it. So this is something that we also saw that we can try to improve within the Met. This additional work they have when they are sharing the data with the partner. And the last one is internal data access. Like I mentioned before, they have different sectors. Each sector produces information. Each sector is trying to access the other information. So they have this issue of, let's say, not sharing the data by itself, but they don't have like a repository that, well, all the sectors can access the information and have no problem with that. They always need to ask for someone, please send me this information, please send me that information. Okay. Yeah, so we looked in all of these challenge, and what we did, we proposed a solution that we like to call a climate data repository that is based on DHIS2. And well, this repository, it has one main goal to be the main climate repository for the Met Office, trying to fix or trying to help them with those challenges that we mentioned before. Okay. Well, how are we thinking these repositories can help them or address those challenges? Of course, for the internal data sharing, we are thinking on the user control or the user permission DHIS2 has. So we have all the information in one repository, so we can have different users accessing those information. We can also say to those users what they can see, what they can do within the DHIS2. So we think this can help them having this control. We have the external data sharing issue with the DHIS2 extensibility. We think we can improve this with the API, the DHIS2 Web API, by creating this automatic process of sending the data to partners and stuff. So they don't need to always sit down and respond to these requests coming from the partners. So they have this thing already automated with all the technology that they can use with the API. And the last one, it's a little bit tricky, like I mentioned, but we think with the climate data app, this is a very, very, very great app, by the way. I am not expert in climate data, but I saw that this app can make very, very easy to have this information on our system. Okay, so I think with this app, we can solve this issue by giving them this, okay, by giving them this easy way to share this data that these partners need, a data that is ready to use, okay? A data that is ready to use so they can share it quickly with the partners. Like I mentioned, they are very busy people, so they maybe, okay, thank you. They maybe don't have the time to sit down and produce the data. With this app, they can share the data quickly. So basically, this is how we are organizing things within this climate data repository. We have the climate data repository here. We have the climate data app as importing climate data. Well, we intend to have also other data source graded, of course. And I think this is the most important thing here, that we intend to have future climate data. this forecast data they produce also included in the repository. And we have some API for them to use to export the data to their partners. Well, within the climate data repository, we have these two sets of, let's say, data sets. We have what we call past data. We have different data sets. This is actually different sources of climate data, but we have this main one that is responsible to show to the public the data they need to see. The intention here is giving full control of the matter of which data they are seeing, because they are responsible for this dissemination of information. So our intention here is to give the Met, okay, full control. You have this data, you have coming from ERA 5 for your sources, but what data people will see, okay? So basically, that is the idea with this multiples data set within the system. We have that for past data, and we tend to have the same for the future data. Well, what we intend to achieve with this is integrated data repository for the Met, a more automated way of sharing data with their partners, sharing data in a structured way, the way they can use already, and improve the data accessibility within the Met. When we did a presentation for the Met about this, what we are building for them, well, they start dreaming with this. So there are a lot of things, a lot of possibilities they are seeing that can be achieved with this repository. One of their dreams is having this improved climate data portal. So this is one thing that we can think we can work with them. They also have this dream to have this mobile app for climate data, and this is something that we think we can also work with them with this climate data repository. So that's it for me. Thank you.
Testing, testing. Can everyone hear me? Okay.
Can you hear this in the room? Yeah, I don't think. Is it
So
okay to
I
do
think
that?
we can project maybe, or
But we have folks online.
online, yeah. But
Yeah.
can you hear?
I don't think you, did you hear this? Can you hear this? Okay, I do hear it online though.
Okay. So maybe if we can project inside, and then for those online, maybe give a wave if you can't hear us. So thank you very much. Matthew Kex, I'm a technical officer at the Department of Digital Health and Innovation within the WHO headquarters. Really glad to be here. There's been so many great presentations, and I want to acknowledge some of the presentations that have just come through. The challenges around data complexity, accessibility, climate, and health. And that's really what we want to talk about today. So Path Digital Square has been partnering with Wellcome Trust, and as was acknowledged yesterday, Wellcome Trust has been a big supporter of DHIS2 Joint Program for Climate and Health to support the harnessing of digital public infrastructure and digital public goods aimed at enhancing climate and health informed data systems. Practically, and I'm looking at our Ministry of Health colleagues here, as well as DHIS2 HISP colleagues, we think about where WHO, WMO, and PATH can add the most value to your national climate and health ecosystems. My colleagues and I'll let them introduce themselves as they come on. We'll give a short overview of our work in this space, and really would love to get your thoughts and your feedback, and also come to our deep dive workshops tomorrow, but more on that shortly. I'll hand over to Timothy now.
All right. Well, thanks for having me. It's great to be here. I'm Timothy Boulay. I'm a bit of a ringer in this, was pulled in last minute to work with WHO and WMO. I started the Climate Change and Health Program at the World Bank. Have been working in this space for about 15, 20 years in different capacities. And now I'm working with these guys to build out the digital health components. So this is not news to anybody. The space of climate and health has been around for a really long time. That first article on the left there is something that appeared in the New York Times in 1992, linking climate change to health, or global warming as it was then known. And then, of course, there was this bangbuster Lancet publication in 2009. It's really been on the agenda. It's really been increasing and growing over the years. And now there's so much energy in the space, which is really exciting. And it's great to see the digital community getting involved as well, as it feels like that's a logical extension of where this is going and where the rest of the world is heading. This also is not news to anybody. This is just an overview of climate change and health impacts. I put this up here because I think that it's really useful to think about some of these discrete health impacts and how that's linked to climate change. And so if you're targeting individual health impacts, or you're targeting sort of a collection of them or all of them in its whole, it might be useful for building these digital public infrastructures, linking these two different areas together. The WHO and WMO, I mentioned I'm here working with both of them. They've been collaborating on this agenda for a really long time. They've formulated their first partnership in 1952. They're just down the road from each other in Geneva. The Joint Office for Climate Change and Health was started in 2014. That was an outgrowth of the Climate Change and Health Department that had been established in the early 2000s. And since they really built up these frameworks on environment and health more broadly, and now more specifically on climate change and health. And they're doing lots of things collectively to build up this agenda. Dr. Tedros, of course, the DG of WHO, is super active in this field. Even going back to the 80s and 90s, he was looking at linkages between malaria and infectious diseases and climate. So this is something that's really near and dear to him, and has been a very strong advocate of this during his tenure. The Joint Office at the WMO operates a bit differently. There's sort of two things here they're doing. They're sort of pulling out sort of opportunities from the climate space, and they're supporting coordination with the WHO, working to get these projects on the ground, listening to what's happening in countries, and working towards materializing impact. There's this great climate services for health framework, which was referenced earlier today. They're working on capacity building and research, and then also product development and delivery, which is really the sweet spot for this community here. Oops. Also, just hot off the presses, released or agreed on the 27th of May, just a couple of weeks ago, is this new action plan for climate change and health, approved in Geneva at the World Health Assembly. This is something that's been long in the making. And as a component of that, there is a singling out of integrated climate and health data and surveillance systems to build integrated climate and weather information at the country level for health systems, right? So syncing this stuff together, really what you're doing. So as you can see, there's now a global mandate to really push this work out there and draw off of what's happening in countries. So the way that the WHO and WMO are thinking about integrated climate and health information systems is you've got digital health systems on one side and climate systems on the other side, and you're building interoperability into these two, sort of syncing up the DPIs to sort of get that data where it needs to be so you can build systems that are really useful for folks, whether or not you're thinking about health or climate. The plan for this is to create a plan. So there is a 3-year action plan that's in process now. It has these 3 components around enabling environment, around digital and data products, which is really sort of the focus for this community, but also human capacity building, getting folks up to speed so they can start to operationalize this work. I'll stop there and I'll pass it to my colleague, Shona.
Thanks, Timmy. My name is Shona Camps. I work for the WHO WMO Joint Office for Climate Change and Health, but today I'm actually here representing PATH, which is the Health System Strengthening Organization that we're all working in collaboration with. So I wanted to talk about one specific area that PATH has been working on in collaboration with the WMO Digital Health Team, the WHO WMO Climate Change and Health Joint Office, and it's specifically around the Global Goods Guidebook. And I know a lot of folks here in this room might understand the Global Good Guidebook specifically for digital health. And what we're trying to do now is leverage understanding how climate change and health, specifically digital health, digital public infrastructure can come together. So from my background, I work mostly in the digital health space, and now looking at the climate change space, I'm sure that a lot of you are seeing that there's this intersection of digital health and climate change, but they're still sitting a little bit separate. And there's a really big opportunity in the digital public infrastructure space to leverage these tools to allow improved implementation and adaptability. So what we're trying to do is expand the Global Goods Guidebook to actually include climate change and health resources. And what this means is creating a compendium or a big resource that essentially looks at all the climate change and digital health goods that are out there. So the tools and resources that a lot of you are actually developing or utilizing and understanding what they look like in terms of maturity, standardization, and interoperability. So what that looks like in practice is we've brought together a whole bunch of climate experts and a whole bunch of health experts, and we've asked them, what is a digital public infrastructure or a digital public good in the climate change and health space, and how is that best used for implementation, adaptability, and essentially how can it be used in the field to further develop this space? So these are some of the indicators that we've ended up landing on. And where we're at right now is we've essentially put out a call. We've heard from the space what's out there, what's been developed so far. As we know, it's both an old and new space. And we've analyzed it against these indicators with a peer review group. And now with that peer review group, we've developed a couple, or we've at least approved a couple of these global goods, such as the DHIS2. And we're moving on from there to try to further develop this ecosystem in this space. So the last call from you all is to give us feedback on what we've done so far. So we have a beta version out there. If you can scan this QR code and actually look into what it looks like right now, we'd really like to hear your feedback. And we also have a session tomorrow that we'd really encourage you all to come out to, and we can hear a little bit more. So thank you so much. Yes.
Sorry, we're not done just yet. We've got one other bit. And so, yeah, just to reiterate, we have 2 sessions tomorrow, at least in person. One will be focused on country use cases of and country implementations in particular. So that'll be a facilitated workshop around what does it mean to actually implement climate data informed health services. And part 2 will be really focused on this global goods guidebook. But again, we'll talk a bit more about that in due course. One last thing I wanted to share is also some other work we're doing as part of this joint program of work, which is really focused on the use cases. So examples of these climate data informed digital services. And again, we saw some previously. So thanks to our Mozambique colleagues in particular for sharing on that work. And I know across the cohort of people who are here at this conference. But I'll take one step back just to maybe give a little bit more context for those who are a little bit less familiar around what WHO's role is in terms of digital transformation. And so whilst this overarching strategy, I'm sure is still somewhat well known, the key part that I want to acknowledge is what does it mean to actually enable a fundamental shift, to actually be guided by that principle of collect once, use many times. I want to acknowledge just my own admiration for the HISP network and the commitment to participatory design and also being people-centered. Design thinking is my background as well. And so really in that vein, what does it mean to be people-centered in health system transformation and really focusing on those end users? And where we take a role as WHO is this idea of it requires an architectural approach that ensures data capture during service delivery can be seamlessly reused for health system monitoring, program management, and global accountability. So as government ministries, and I know many of you are in the room today, pursue digital transformation, there is obviously significant architectural and semantic challenges. And so whilst several of these challenges are well known to you all, I want to take this opportunity to just sort of reiterate them as a shared challenge, but again, as a shared opportunity as well to make change. The conventional translation of WHO guidelines, right? So where we start is in our normative role, from evidence-based recommendations into digital technologies, it too often results in a fragmented ecosystem. And we have this sort of black box of tools, right? And there's all of these legacy systems that are kind of talking at each other or talking across each other. So what does it mean then to have these difficult and costly to maintain systems? And what does that mean for continuity of care and longitudinal personal health records? So what we're trying to do is we're trying to address this systemic breakdown in the translation of normative guidance into well-specified technical requirements for implementation partners. So the smart guidelines approach is one such way of actually achieving the strategic architectural shift from moving from a reactive integrative model to a proactive standard-based ecosystem. Again, I'm doing a lot of acknowledgements, I noticed today, but there's been such great presentations. And the one yesterday on the fire implementation guide application, I think there were several, maybe of you here that were in that session, and just illustrating what it means to actually use standards in this interoperable way to achieve the change that we're looking to occur. Particularly here in this diagram, just want to point out to this idea of at the point of data collection, right? We have that core semantic challenge where disparate systems are using proprietary data models, identifiers, and terminologies, making data sharing aggregation fundamentally difficult. So to enable the comparison and synthesis of this data from various sources, a data normalization layer becomes architecturally essential. And so within this layer, we agree upon a data model. Here is FHIR to serve as that standard. We then map and transform data received from the various sources, source systems to conform to this standard data model. And ultimately, we're looking to achieve a reduction in the number of bespoke point-to-point integrations required, right? So when it goes into DHIS2, it's semantically consistent and standardized. So how does this sort of apply within the sort of climate and health system and what these use cases that I sort of mentioned before actually mean? So we're applying this same sort of architectural principles we discussed specifically around digital public infrastructure for complex cross-sectoral challenges of climate and health. So these core problems, again, of interoperability between critical data domains, meteorological data, public health services, all right, that are not designed to communicate. What does it mean to actually make them communicate? So one approach is to document that necessary digital public infrastructure to bridge this gap, using smart guidelines as the methodology to create a minimum set of data and requirements for specific use cases. So one demonstrator we're focusing on is how to operationalize a country's heat health action plan. So this is again with regards to extreme heat, by tackling the challenges of interoperable alert systems. Our second use case addresses the documentation gap in something that's been around for a long time, and we saw it just before, vector-borne diseases, and where effective surveillance requires integrating, again, climate and data. So ultimately, none of this should exist in a vacuum, and none of this is really that new, right? But there is an opportunity, I think, to leverage this renewed push for better interoperable climate and health DPI and DPGs. And so that's why this was a bit of a taster, a lightning talk again, as it was, to also invite you again to come join us tomorrow where we can actually go and we really want to hear from your experiences and your stories in countries, again, in implementing this work. What are some of those challenges? What are some of those opportunities? And how, again, can this question around minimum data sets and interoperability actually start to unlock some of the potential that is there already? So anyway, with that, thank you very much.
Okay, we have reached the end of our scheduled time, but I think if anybody wants to ask questions, people might be willing to hang out for a few minutes. Does anybody in the audience have a question? Okay. No questions. I won't keep you, so feel free. The coffee break is starting now. Our next session in this room will begin in 20 minutes, I believe, maybe 30. I'll check the schedule. 3 o'clock. Okay, nice. We have longer breaks. Very good. Awesome. Thank you all for the presentations. That was great.